Adrian Di Bisceglie. I'm president of AASLD this year. Welcome to this press briefing. I went through the book and picked out a few slides that were of interest to me, a few abstracts, excuse me, that were of interest to me and that seemed to be thematic for this year's meeting. And I'll run through them, and I'm happy to discuss them with you and try to answer your questions as best I can. Liver transplantation remains a very large part of what we hepatologists do. It's the ultimate life-saving treatment for patients with either acute or chronic liver failure. We do about 6,000 transplants per year in the United States, and that number climbed and then reached a plateau maybe 4 or 5 years ago. We've been stuck at about 6,000. And it seems to be in large part because of a limited number of organs being available. The two abstracts that I picked out for discussion describe some good outcomes for patients with HIV, and then some issues related to regional sharing of donor livers. So let's transition to that. Well, let me do this first. So a lot of the liver diseases that we transplant for, hepatitis B and hepatitis C, travel with HIV. So there's large numbers of individuals co-infected with HIV and hepatitis C, HIV and hepatitis B. So we've struggled with what to do with these patients. When you transplant somebody, obviously you give them immunosuppressive medications. They are often already immunosuppressed, and you put them at greater risk of opportunistic infections. And then the other problem is interference between the anti-rejection medicines, tacrolimus or cyclosporin, and their antiretrovirals, because they are particularly protease inhibitors. HIV protease inhibitors are metabolized by the liver, as are these anti-rejection drugs, and the two sort of interfere with each other. So there have been previous reports of experience at a few centers with transplanting patients with HIV, and they have not been good. Most of them for HIV and hepatitis C co-infection. This particular report relates to patients with liver cancer. Obviously, the liver cancer develops also on the background of chronic viral hepatitis. This was a retrospective cohort of 367 HIV-positive patients with hepatocellular carcinoma over a period of just over 10 years. From 38 centers, and they were in 8 countries. So this is an unusual thing to do, that is to transplant somebody with liver cancer and HIV. So to get enough cases, they had to go to these 38 centers in 8 countries. And what they did was they looked at the outcome of the patients according to whether they were transplanted for their cancer or had other potentially curative treatments. So surgical resection, radiofrequency ablation, or percutaneous ethanol injection. Each of these treatments we consider to be potentially curative for cancer. So there were 27 patients transplanted, 108 with other potentially curative treatments. And it turns out that the patients who were transplanted had the highest survival. At 2 years, 92%, at 5 years, 85%. These numbers are very comparable to what is seen with other patients undergoing liver transplantation for other indications. Compare that to a 2-year survival after surgical resection, 77%, RFA, percutaneous ethanol injection, 41%. And you see here the actual survival curves, the red line being with transplant. So I think the major reason for this, for the poorer survivals with these other treatments, is the HCC comes back. You do a surgical resection, the rate of development of new tumors is about 15% per year. Same for RFA, same for percutaneous ethanol injection. Whereas if you do a liver transplant, you take out the diseased cirrhotic liver that is the seed for liver cancer, and so the cancer doesn't occur. And I think we have progressed in our understanding of how to manage these patients, how to select patients with HIV, so don't pick the ones that are already severely immunosuppressed, and then how to manage them post-transplant, how to adjust their anti-rejection medicines so that they don't become overly immunosuppressed. So I think a positive report on saying that it is possible to transplant patients with HIV. So this next abstract is entitled Allocation of Livers Based on the Share 35 Policy, and the conclusion is in the title. Has no impact on waiting list mortality and worsens organ utilization in UNOS Region 4. So as you may know, the UNOS is the organization that regulates liver transplantation in the United States. It divides the country into regions. And this Share 35 policy was introduced within the last year or two. And the Share 35 is shorthand for sharing livers for patients who have a MELD score of more than 35. MELD score is model for end-stage liver disease. It's a measure of the severity of liver disease. A normal healthy person will have a MELD score of 6. It goes up to as high as 40. We don't even think about transplanting anybody until their MELD score gets to 15. And in my center in St. Louis, we will transplant patients in somewhere between the 25 and 30 range. But there are many parts of the country where there are just not enough livers. There are many patients listed. And so the patients, in order to get to the top of the list, have to be sicker. And for patients who have a MELD score of more than 35, these patients are desperately ill, often in the intensive care unit, with a very high likelihood of dying within the next 90 days. So the notion was, well, if we take those sickest of the sick, maybe we can move livers from an adjacent region to transplant these people to decrease the mortality rate in those regions. It's been a controversial move, as is every change in allocation policy, because every change will benefit some transplant centers and will adversely affect other transplant centers. That is, the ones where the livers are exported from. And they need those livers for their patients. They want to do the right thing for their patients. And of course, the hospitals are interested in the transplant volumes, and if they're low, that affects a hospital's performance. Here's the bottom line from the study from a large transplant center in Region 4. So in the pre-Share 35 era, there were 186 patients in total. 10% of them died on the waiting list. 18% of them were too sick to transplant. Post-Share 35, it's 12.3% and 15%, essentially unchanged numbers. So this particular center saw no benefit, and in fact, the mortality rate was higher after the implementation of Share 35. So I don't think this tells us, let's just read through this summary slide, and then I'll give you my own perspective on that. Although 19% more livers were procured, so they did manage to import some livers, there was no change in the percentage of patients removed from the list for death or too sick to transplant. So I think this Share 35 thing has been controversial. It has really had a big impact on some transplant centers from regions where they'd been transplanting quite well, and suddenly the supply of livers dried up. I've heard this from my colleagues, and they've been shipped often to large cities, Los Angeles, Chicago, and so on, because they have more patients on the waiting list, and they have sicker patients on the waiting list, and they have more patients with a MELD score of 35. And I think that this abstract is sort of a signal that maybe this policy didn't work out the way it was planned. And I think this will lead to maybe a reevaluation at a national level of, did we really do the right thing in terms of introducing Share 35? Okay. Fatty liver disease. I think we've been talking about fatty liver disease at these press conferences for a number of years. I actually remember I gave a presentation some years ago, and somebody asked, we were talking about how frequent fatty liver disease, and somebody asked if we were perhaps disease mongering. But it turns out that indeed fatty liver disease is very common and often becomes very severe. And we've really appreciated that progression over the last 4 or 5 years. So I won't talk too much about how common it is or even the pathogenesis so much, but I'll point to 3 abstracts that say that weight reduction surgery, bariatric surgery, is beneficial. Liver biopsies, it remains the mainstay of diagnosis. There's no blood test or x-ray or ultrasound or anything that we can reliably use to diagnose fatty liver disease. And so the next abstract is about liver biopsies of non-alcoholic steatohepatitis, fatty liver disease, among obese children. So here's the abstract on the effects of bariatric surgery on severe liver disease in morbidly obese patients with proven NASH, a prospective study. And these are individuals having a liver biopsy before and after bariatric surgery, before and after. And what is measured here is the presence of NASH. There's a scoring system developed by Dr. Elizabeth Brunt, referred to as the Brunt score. Brunt should be capitalized there. And then we see here the scoring 0, 1, 2, 3. And you'll see that after surgery, the proportion with the 0 score is much higher. So we're seeing the features of NASH actually resolve after bariatric surgery. You also see improvement in the degree or amount of liver fibrosis. So 0 was 27%, became 43% using this Medivir scoring system. And this was 82 patients with paired liver biopsies before and after bariatric surgery. The problem is, of course, bariatric surgery is reserved for the morbidly obese patients. So there are individuals who may have quite severe liver disease who are obese but not that obese, not enough to justify surgery. But bariatric surgery has been known for some years now to be the thing that probably works best for a treatment of severe fatty liver injury in the right type of patient in the right setting. I already talked about the frequency of pediatric NAFLD, non-alcoholic fatty liver disease. As we have seen the epidemic of obesity rise here in the United States, that has extended to children. And what's been of concern is that some of these children appear to have quite severe liver disease, even young children under the age of 10 with cirrhosis from fatty liver disease. And this has been studied in the NASH CRN. So the NASH, we've already said, is non-alcoholic steatohepatitis and Clinical Research Network. This is an NIH-funded network that's been in operation now for approaching 10 years. And they have a pediatric component to this. So they've enrolled children and done paired liver biopsies. And this is a report of 102 paired liver biopsies. Interestingly, 91% of them were boys. This seems to be a condition that affects Hispanic boys predominantly. 72% were white. And here's the age at first biopsy. So between 4 and 10 and 11 to 17. You see the proportions over there. And blue is definite steatohepatitis, NAFLD, but not NASH. So I think the interesting thing about this is that the liver biopsies in the children look different. There is a so-called pediatric pattern of NAFLD with the zone 1 steatosis or fat. And then over time, it appeared that they evolved to the more adult pattern of steatohepatitis. Some of them had resolution of their NASH to NAFLD, but most of them appeared to transition to this adult type of NAFLD. I don't think this really tells us how many of them progress to severe liver disease or who might develop cirrhosis or may need a liver transplant. But this remains very worrying, and we know that there are, among adults, fatty liver disease is the condition that is rising at the largest rate as an indication for liver transplantation. It also appears to be rising as a risk factor for liver cancer. And you could predict that. We're going to talk about hepatitis C in a moment, but as we more effectively treat hepatitis C, we may be doing fewer liver transplants for hepatitis C, but I think we're going to be doing more for fatty liver disease. And I think we need a clearer understanding of what happens to these children over time. I have a couple of abstracts related to basic science because AASLD's roots are in basic science research, and this remains strong in the liver community. I picked out an abstract related to the development of human hepatic organoids and then inhibitory or siRNA, silencing RNA. So for the organoids, I don't have a data slide, but essentially the issue here is for a long time we've been able to study either individual liver cells, hepatocytes, or the whole organ. You take out the whole liver and you can perfuse it and it can make bile, or you study individual hepatocytes. So the hepatic organoids represent little clusters of hepatocytes or and other cells that look like a liver. They don't have bile ducts or anything like that, but they grow on a matrix, and you can do various things with them, including perhaps the suggestion from the authors is use these as a tool to test for drug hepatotoxicity. So this is one of the big challenges for drug manufacturers is you can take your drug, and there are various standard tests. You give it to animals. You start with rodents and then maybe monkeys. Excuse me. And you test it in vitro and so on to see if it's toxic. But every now and again, we'll see a drug will slip through, gets approved, and then as it's used widely in thousands or tens of thousands of people, we see that it turns out to cause liver injury. And it may be that these hepatic organoids could be a suitable tool to screen for drug injury. So these authors made organoids in two ways, and one of them that I think is really interesting is to take non-liver cells and transform them into liver cells. Thank you very much. Is to take non-liver cells and transform them into liver cells through the iPSC process, induced pluripotent stem cells, which you can genetically manipulate to become all kinds of cells, including liver cells. And so within 16 days, these authors obtained vascularized hepatic-like tissue that contained hepatoblasts, cholangiocytes, hemogenic endothelium, stellate-like cells, and hematopoietic progenitor cells. The liver in utero actually is the place where blood is made. And so you take these organoids and they go back to their primitive roots, and they can make blood cells again. And you could see where organoids like this might be used to actually treat liver disease. Take a patient perhaps with fulminant hepatic failure who's dying from a lack of liver mass. Perhaps an infusion of these organoids might help them, or perhaps a patient with cirrhosis who's on the edge could have an infusion of organoids enough to improve their hepatic synthetic function over time. So this is sort of a technological advance, but a big one, I think, with lots of potential use down the road. Okay, the other basic science abstract that I mentioned, that I wanted to mention, is a hepatocyte-targeted RNAi-based therapeutic for alpha-1 antitrypsin deficiency associated liver disease. So alpha-1 antitrypsin deficiency is an inborn error of metabolism. The gene frequency is about 1 in 50, which makes the actual disease, where individuals are homozygous for the Z allele, about 1 in 250. So it's not a rare disease, not that common, but not a rare disease. And it causes lung disease. It causes emphysema because of the absence of the alpha-1 antitrypsin. But this abnormal protein, the reason that the protein isn't produced is that it folds incorrectly. So proteins normally have a three-dimensional structure. They fold, and then they get exported from whatever cell they're made in. But because alpha-1 antitrypsin is folded incorrectly, it is not exported by hepatocytes, and so it accumulates in hepatocytes. eventually it kills that hepatocyte in which it is accumulating. So what these authors did was to then to create a silencing RNA to decrease the production of alpha-1 antitrypsin. So it's a paradoxical thing. You take these patients, that, if they're patients, these are animal studies, but measure the level of alpha-1 antitrypsin in their blood, and it's very low. And now this is a silencing RNA. You want to decrease the production, but the reason you want to do that is you want to decrease the production within the liver cells, hence decreasing the accumulation of the toxic alpha-1 antitrypsin. And so they found that a single injection into transgenic ZZ mice reduced the serum levels of alpha-1 antitrypsin, reduced liver mRNA, and reduced the aggregation of the polymer as well. They treated non-human primates with this as well, and this holds great promise for the treatment of patients with alpha-1 antitrypsin-associated liver disease. So this has been a neglected disease for many years. For the patients with a lung disease, what we do is infuse, we purify alpha-1 antitrypsin from plasma of normal individuals and infuse it into them, raise the levels. It protects them a little bit from the lung disease. But we've had nothing for the liver disease. We diagnose it and we say, live long and prosper, but this actually offers prospects for treatment. And this is a disease that affects children. It often is detected in infancy. And then it sort of seems to quieten down and then reappears later in adulthood, or may reappear for the first time in adulthood. So I think this is an important prospect for treating this disease. Okay, viral hepatitis. I think we need to, everybody wants to talk about hepatitis C, and it's a very exciting topic, but we need to have a continued focus on hepatitis B because it remains a problem here in the United States and abroad. And I have two abstracts related to this to show that HBV infection rates are 4 times higher than the general population in our veteran population here in the United States. And also the results, benefits of treatment with PEG interferon plus tenofovir. So firstly, a study from the VA on serologic testing rates of U.S. veterans with hepatitis B. This was a retrospective study of care quality and outcomes among a national sample of U.S. veterans. 21,000 veterans identified in this time period. The first thing was they found out that the rates of recommended laboratory testing for hepatitis B range from 26 to 73%, lower than expected. We have standard recommendations of who should be tested for hepatitis B, and I think what this finding was these recommendations were not followed. And then among patients with hepatitis B, the rates of screening for liver cancer and treatment with antiviral therapy were low as well. And only 38% got antiviral treatment. This is provided by the authors and shows a cascade of hepatitis B care at their VA. And you can't quite read the bottom, and so I'll read it for you. Starting from the left, this bar is the total, those of the patients with hepatitis B. Then the proportion who receive VA care is 96%. The proportion with the ALT level, the liver enzymes were tested, 72%. Diagnosed with hepatitis B, 56%. Referred to a specialist, 31%. Had a test for hepatitis B virus DNA in serum, 26%. It looks like actually treated, 25%. And then screened for hepatocellular carcinoma, 13%. And I really believe, based on my own experience, that what is described here within the VA system is mirrored in the rest of the country. Individuals who should be tested for hepatitis B are not being tested. And briefly, those recommendations were updated by the CDC in 2008 to call for screening of all persons born in countries where hepatitis B is endemic. Wherever the rate of hepatitis B is more than 2%, the individuals who immigrate to the United States need to be tested. And if you look at the map that the CDC provides, that's everywhere except Northern Europe, Australia, and a little bit of Argentina. So if a person comes from anywhere in Africa, anywhere in East Asia, anywhere in Eastern Europe, Southern Europe, the recommendation is that they be tested. because they may have a high frequency. Among Asians, we have screening programs in St. Louis in St. Louis that we've been working with the community now for 8 years, 10 years. The frequency of hepatitis B ranges in the 8 to 9% range. So that's nearly 1 in 12 individuals in these Asian communities have hepatitis B. And the only way you will find out is by testing them. And I think this VA experience tells us that that has not been happening. So we need to raise awareness about this. This is a study sponsored by Gilead, presented by Patrick Marcelon, looking at the combination of tenofovir and PEG interferon. Tenofovir is a nucleoside analog that's been FDA approved, widely used for hepatitis B for years now. It's obviously also widely used to treat HIV. PEG interferon, or interferon in general, was our first available drug to treat hepatitis B. And we know that tenofovir is very highly effective in the 95, 97% range in controlling hepatitis B. Within a year, you can bring the hepatitis B DNA levels down to undetectable. You can make the ALTs normal in about 90% or so, but you hardly ever cure the patient. When you stop the tenofovir, the hepatitis B just seems to come right back up in most individuals. So this was an attempt to see with this combination of drugs whether one could cure hepatitis B. The primary endpoint was loss of hepatitis B surface antigen. So if somebody loses hepatitis B surface antigen, that's about as close as we can get to saying the person is cured. At week 72, there were 3 study arms, as described here: tenofovir plus PEG interferon for 48 weeks or for a year, tenofovir and PEG interferon for 16 weeks, and then tenofovir alone, PEG interferon alone, and you see here the outcomes over here at week 48. The blue line shows the best outcomes, 7%, 7.3% with tenofovir and PEG interferon for a total of 48 weeks. The other 2 combination arms had this 2.8% response. Tenofovir alone, a flat 0. And this is the medicine that we're using in most of our patients with hepatitis B in this country. Interferon is a little more widely used and prescribed in Europe. But at the end of the day, you have to say, well, is 7.3% really that good? Yes, it's better than the 2.8%. It surely is better than 0. Is it worth the effort, though? And I think the answer is it may be, but the real answer is we need new treatments to treat hepatitis B. We sort of got complacent when we got tenofovir and entecavir. We said we can control hepatitis B in most everybody. But the pharmaceutical industry got this, and there's a large amount of investment into studying new pathways to attack in trying to eliminate hepatitis B. It's going to be a technological challenge, but the reason for it is because even if we do our best with our current medicines, we get to 7.3% cure rate. Hepatitis C. So I think everybody is aware that we have made incredible advances in treatment in the last year or 2. We now have a handful of new drugs FDA approved and available. So the results of those clinical trials are what we've been all excited about at the last several AASLD meetings. But I think we now need to turn our attention to how to deploy those drugs. We need to study how the new agents work, how do they work in difficult to treat patients, and how do we deploy these treatments on a large scale? How do we get them to the people that need them? Which brings up the need for screening for hepatitis C. So there are a couple of abstracts that address these. This was a late breaker abstract. We didn't get any slides from the author, but it's entitled Safety and Efficacy of New DAA-Based Therapy for Hepatitis C Post-Transplant, Interval Results from the HCV Target Longitudinal Observational Study. So I'll mention a disclaimer both for this abstract and the other. I don't think I'm a co-author on this one, but I am involved with HCV Target. It is a consortium of about 55 sites in the United States and Europe, both academic and private practice, and has a very interesting system of having a registry for patients who are treated. the participating sites essentially have data from their patients abstracted centrally. The patients are not actually enrolled in a study. They're just treated as though they would normally be treated, and they get their medicines, take their pills, but then the data is abstracted from that. This goes into a large database that is then analyzed, and hence we get this abstract and the other one that I'll show you. And this particular one was about treatment in the post-transplant setting. And we've seen reports of post-transplant. You'll see them here at this meeting, but they normally are single sites. A single site might report on 10 patients or 12 patients or something like that. This was 206 subjects. Remember, these treatments only became available earlier this year in 2014, so a lot of these individuals have not completed their treatment and follow-up yet, so there's an efficacy cohort of 73 where there's a known virologic outcome. The virologic outcome that's used is SVR, sustained virologic response, at week 4. We've learned that although the official SVR date is week 12 post-treatment, week 4 pretty much is pretty darn close to week 12, and we really need to see these data that are emerging so rapidly. So the mainstay of treatment here was the combination of cimeprevir and sofosbuvir. Interestingly, no episodes of acute cellular rejection were noted, whereas when we used interferon, we did see episodes of rejection apparently induced by the interferon. 4 patients developed renal failure, but after transplant, this is a normal event, often associated with the underlying severe liver disease and the use of calcineurin inhibitors as immunosuppressives. So these sofosbuvir-based regimens appear to offer SVR4 rates of 70 to 88% post-transplant. Serious adverse events and discontinuation rates are low, including an absence of rejection. So liver transplantation, we talked about at the beginning, is sort of the last resort. When you can't do anything else, the patients develop liver failure, we say we can save you with transplant. And we've been doing that for years now with patients who have hepatitis C, knowing that the recurrence rate of the hepatitis C infection is 100%. Everybody gets reinfected. About a half of the people reinfected get severe or significant hepatitis. But if you look at survival rates over the course of 3 years, 5 years, in patients transplanted for hepatitis C, they are substantially lower than those transplanted for other diseases. They've been acceptable, but still lower than transplant for other reasons. And I think what this abstract says is we can potentially fix that. We have now, we were previously treating with interferon and ribavirin, and it was only very selected patients. These treatments were very toxic, particularly toxic in the post-transplant setting. And you could get SVR rates perhaps on a good day of about 20 to 30%. Now we're approaching 90% in this post-transplant population with a combination of cimeprevir and sofosbuvir. And, this is just a bunch of doctors doing their best guessing as to how to use these drugs. There are no large-scale prospective studies, sponsored by industry that have been reported yet. They are underway. So what you're seeing here is doctors trying to save the lives of patients by taking the available drugs, trying to use them as best they can, and with surprisingly good effect, I believe. Okay, this one I am a co-author on. This is also from HCV Target on the safety and efficacy of sofosbuvir in combination with cimeprevir plus or minus ribavirin in patients with HCV genotype 1. Interim results of a prospective observational study. We see here something about HCV Target being a consortium of academic and community medical centers. Some baseline characteristics of the patients. This was 1,000 patients. The number receiving sofosbuvir and cimeprevir was 772. 217 got ribavirin in addition. I'll remind you that the so-called COSMOS study, which was a phase 2 study using sofosbuvir plus cimeprevir for the first time, had perhaps 25 patients in it. And that study was the basis for the use of these two drugs in combination. I'll also mention that that combination was recommended in the in AASLD's guidance And that guidance was published in January, and that seemed to drive the use of cimeprevir and sofosbuvir. I'm told, although I haven't seen it for myself, that the FDA approved this combination about 2 or 3 days ago, based on AASLD's guidance and data like this that come from HCV Target. So we see over here on the right the SVR4 rates being, in the 85 to 90% range. Genotype 1A cirrhotics, the losers at only 82%. Genotype 1B non-cirrhotics at the 94% range. So in this real-world experience, we see large numbers of patients being treated with cimeprevir, sofosbuvir, and doing very well with SVR rates around 90%. This may be the final abstract that I picked out, which was on a community-based approach to hepatitis C diagnosis in high-risk populations, referred to as Check Hep C. So this, the Check Hep C background, this was implemented in 2012 as a demonstration project to increase HCV screening, diagnosis, and linkage to care. The funding is listed here. But the New York State, I'm not sure I can quote the details, but is one of those states that has pushed for, if not mandated, hepatitis C screening of baby boomers. And so this is an example of a group getting together to say, okay, the state is telling us we have to do this. How do we get it done? What kind of programs can we put together? What are the results? So they screened 4,700 individuals in this period, in this 1-year period. Of those, 880 were HCV antibody positive, 512 were RNA positive. The overall HCV prevalence was 14%, 5.8 times higher than the estimated New York City prevalence of 2.4%. And the national rate of HCV infection is about 1.4%, so this is 10 times higher than that. Persons born in 1945 to 1965, the baby boomers that are targeted for screening, had the highest prevalence at 14%. Injection drug users were 20 times more likely to have HCV infection. So the conclusion then that the program was effective in identifying, diagnosing, and linking HCV positive persons to care. The method of providing HCV RNA tests immediately after antibody positive test is a successful strategy that can be used to increase rates of complete HCV diagnosis. I didn't really discuss that, but one of the challenges has been patients may test positive for antibody to hepatitis C, but that would be because they have resolved their HCV infection. Somewhere between 15 and maybe 40% of patients resolve their infection, so they'll remain antibody positive. So to know if somebody's at risk of liver disease progression, you have to check to see if they're still viremic. So the usual way would be you do an antibody test, and then they'd be positive, and then you send a sample for hepatitis C RNA, and then several weeks later you'd have a result. You'd try to contact the patient. But in this kind of community screening situation, these are often individuals you may only get one crack at to screen them and to find them as being positive. And you need to turn around that HCV RNA testing real fast so you can contact the patient, let them know they're infected, and link them to care so they can get into the medical system to be evaluated and then potentially treated. Let's see, I had made a couple of summary slides, but they didn't quite make it over. So I'll just try to summarize then as best I can. I've said a few things about liver transplantation, which seems to be stalled at this number of 6,000. We have problems with how to best allocate livers, and the Share 35 policy doesn't, at least based on experience in one region, doesn't seem to be the solution. Probably the solution, I believe, is programs and policies to try to increase organ donation, is what I think we really need to do in this country. Fatty liver disease is a problem to keep an eye on. It occurs in children. We know that it causes bad outcomes. It needs more study. We need more effective treatments. Basic science, hepatic organoids may be a big thing in the future, may give us tools to test things in vitro, could perhaps have some potential for therapeutic use in the future. The silencing RNA approach for alpha-1 antitrypsin is an example of a technology to treat a particular liver disease, but also this is a disease for which we've had no treatment in the past, so this is potentially a very useful technology. Hepatitis B, we need new drugs to treat hepatitis B. We have to properly screen the population at risk so we know who has hepatitis B so we can offer them treatment. Hepatitis C, the battle is not yet won. We have incredible treatments. We've made fantastic advances in developing treatments to eliminate hepatitis C in particular patients. We now need to think about how do we deploy those drugs. How do we find the patients, screen them? How do we link them to care? How do we get them to take their treatment until they are treated and cured of their hepatitis C? So I'll stop there and happy to take questions.